Hello all, welcome to the next edition of EM Diaries. I'm Dr. Ajith Venugopalan. This session we will be covering neuromuscular blockers. Neuromuscular blockers are agents which are used to produce muscle relaxation. The agenda for this session will be to cover about skeletal muscle relaxants, their classification, mechanism of action, reversal agents, and special situations. Let's bring it about a case. You have a 72-year-old male brought to the ER in an unresponsive state. His airway is compromised, breathing is bradypnea with saturation of 68%. How do you proceed forward? As discussed in the previous slides or previous session about rapid sequence intubation, we are proceeding for this case with rapid sequence intubation. Now comes the biggest next question, the drugs, especially which neuromuscular blocking agent are you going to use? Let's see and let's go through the neuromuscular blocking agents. Skeletal muscle relaxants. Skeletal muscle relaxants are drugs which are used to induce muscle relaxation. They are classified into three: peripherally acting, centrally acting, and direct acting. The peripheral acting agents are what we are going to discuss in this session. The peripheral acting neuromuscular agents, or known as neuromuscular blocking agents, that is NMBA, are chemical agents that are used for paralysis of skeletal muscles by blocking the movement of the neurotransmitter at the neuromuscular junction. And specifically repeating, these drugs are used to block the movement of neurotransmitters at the neuromuscular junction. So the whole drugs are going to act at the neuromuscular junction. Hence, it is broadly divided into two: competitive blockers or non-depolarizing agent, or non-competitive, that is depolarizing agents. These are the classification and these are the common drugs that comes under them. So non-depolarizing or competitive are D2-bucuronium, any NUIM ending with. Most of the drugs are going to end in IUM or NIUM, that is pancuronium, vecuronium, atracurium, mevacurium. Or depolarizing agents which are non-competitive blockers, succinate choline, are most commonly used. Let's come into the normal mechanism of action at a neuromuscular junction. So you all are aware about neuromuscular junction. Neuromuscular junction, where a peripheral nerve is going to come, where it is going to act at the striatal muscle, and there is a junction between it. What is going to act or what is going to happen at this junction is that the neurotransmitters are going to pass into this junction, and then they are going to act on the neuromuscular junctions receptors or neuromuscular receptors. And these receptors are going to, there are certain things that is going to happen, chemical reactions is going to happen, and that is going to allow the neurotransmitter inside. And these receptors are mostly the nicotinic acetylcholine receptors, are having different units. It has mostly 4 to 5 units. It has 2 alpha units, 2 beta units, and a cation channels in between. And once these receptors are stimulated, it opens up and the transmitter goes inside. This is the basic deputation. Once the action potential comes in, the acetylcholine, which is the neurotransmitter, is going to move into the neuromuscular, the presynaptic area. So this is the presynaptic, and it is going to open up the presynapse and it's going to move into the neuromuscular junction. And then through the neuromuscular junction, it is going to move into the muscle receptors, and from the acetylcholine esterase receptors, it opens up the channel and it goes into the muscle, and it produces depolarization or muscle contraction. Then acetylcholine receptors, acetylcholine which is present at the neuromuscular junction, whatever is remaining, it is going to get broken down by the acetylcholine esterase. Now, how does it act? The mechanism of action, we have to understand the normal physiology that is going to happen. The acetylcholine, as said earlier, is coming from the presynapse. Once it is stimulated, it moves into the synapse, then it is slowly comes and get into the receptor, acetylcholine receptors at the motor end plate. Once it goes into the receptor, it is going to open up the receptor and is going to get into the muscle, and that is going to produce depolarization, that is basically contraction. And once the stimulation phase is over, it is going to produce relaxation, that is repolarization. So acetylcholine is coming from the presynapse into the synapse, into the motor end plate, gets onto the receptor, acetylcholine receptor, and is going to produce depolarization and then repolarization. The most important thing, another thing that you have to know is the acetylcholine is then broken down by the acetylcholinesterase, which is in the synapse, and that is how it is broken down. When it comes to non-depolarizing agent, the major change that happens with the non-depolarizing agent is the word itself. It is non-depolarizing. So non-depolarizing, it is going to produce no depolarization. Understand very clearly, this is the basic difference between non-depolarizing and depolarizing agent. Here, the non-depolarizing agents is going to come and it's going to stick onto the receptor, and it is going to just block the receptor. As a result, there is no depolarization. And because there is no depolarization, there is no contraction. And because there is no contraction, the muscle go to paralysis. Okay. But when it comes to a depolarizing agent, what happens here is this is going to, like succinyl colon, it is going to stick onto the acetylcholine receptor because it has some structural similarity with acetylcholine. It's going to stick onto the acetylcholine receptor, and it is just stick onto it, and it's going to produce persistent depolarization. It's going to keep on stimulating the muscle, and as a result, there is a persistent depolarization that is going to happen, and there is a muscle contraction, there is a fasciculation followed by paralysis. So that is how the phase goes. So understand this very clearly. The basic difference between the three, the normal one where acetylcholine is going to come, going to stick onto the receptor, produce depolarization, broken down by acetylcholinesterase. Depolarization is a competitive blocker. It's going to stick onto the receptor. There is no depolarization. There is paralysis. Whereas depolarization agent, structural similarity with acetylcholine makes them go attach with the receptor, produce persistent depolarization, and as a result there is a fasciculation followed by paralysis. The succinylcholine is broken down by pseudocholinesterase. Now let's move on to the most of the common uses of neuromuscular blockers. Neuromuscular blockers, it facilitate endotracheal intubation. It is used as an adjunct for general anesthesia, again for muscle relaxation. It helps in facilitating endoscopy procedures, and for electroconvulsive therapies in psychotic patients to control convulsions. These are used, and is also used in certain cases of tetanus and epileptic convulsions. So these are the different uses that comes to neuromuscular blockers. From ER point, it's mostly used for rapid sequence intubation. Let's come into in depth about competitive blockers or non-depolarizing agents. As said earlier, non-depolarizing blockers doesn't produce depolarization at the muscle junction. So these drugs are mainly divided into their duration of action. It is into three: long acting, intermediate acting, and short acting. Long acting are T-tuberculin and pancuronium. Pan means pan, lengthy. Intermediate acting are atracurium, vecuronium, and rocuronium, whereas short acting is mivacurium. So these are the different agents. Now there is another classification according to molecular construction, that is benzyl isoquinolines agents and aminosteroid agents. Atracurium, mivacurium comes in the first category, whereas the other three comes in the second category. The first category drugs are not commonly used in rapid sequence intubation. Now come into the mechanism of action of competitive blockers. Already been discussed. These are going to the antagonist, that is basically acts as an antagonist, the drug. These are going to stick onto the motor end plate or the skeletal muscle at the nicotinic receptors, and it is going to block the receptor. And once it blocks the receptor, there is no depolarization that is going to happen. The action is it is going to produce flaccid paralysis, and the order of muscles that is getting affected are extrinsic muscles of the eye, followed by neck muscles, then face, hand, feet, trunk, and the respiratory muscles. The recovery is in the reverse order, and one thing that you have to clear is both consciousness and appreciation of pain is not affected. So always understand, whenever you are using a muscle relaxant, you should have a combination with a sedative agent, because consciousness is preserved with muscle relaxant. Some older agents like tuberculin block the autonomic ganglion, reducing the ability of the sympathetic nervous system to increase heart contractility and also the rate in response to like hypertension or any stress or anything like that. In contrast, pancuronium, which is one of the long duration drug, it blocked the vagal muscarinic receptors in the SA node. As a result, because it is a vagal inhibition, it produced tachycardia. All newer agents, as we have mentioned, all newer agents like atracurium, vecuronium, rocuronium, are devoid of the significant autonomic effects in their recommended dose. Hence, the effects on heart rate and BPNR are negligible. Just have this in your mind. And one more thing I want to add is certain drugs can produce histamine release. When compared to atracurium and vecuronium, both are somewhat same, but atracurium appears to have produced a higher incidence of histamine like reaction than vecuronium. Hence, vecuronium is, when compared to both, and compared to atracurium and vecuronium are preferred agents in patients with history of asthma and other allergies. Hence, the adverse effects, as discussed earlier, it can produce cardiac instability. Very rarely, instability is very rare, but it can produce a mild amount of hypotension, tachy, respiratory paralysis, bronchospasm, and if always it has a risk of aspiration. Understand these things, because it may not be the hypertension, tachycardia and all may not be an obvious finding whenever you're doing a procedure, but these can happen. So always have a broader mindset when such cases come into play. The advantage of the newer agents, I've told that there are certain newer agents like atracurium, rocuronium and all, which have less histamine release, hence less side effects. And they do not block the autonomic ganglion, and as a result, it has more stability, and its spontaneous recovery is also there. Spontaneous recovery in the sense, when compared to other agents of competitive blockers, this has a faster recovery. It is having a faster recovery when compared to the other agents. That's one thing that you have to be clear. It is not something which has to be compared with succinylcholine, but when compared to other competitive blockers, it has a faster recovery. And atracurium is eliminated by Hoffman's elimination, and mivacurium, as I told earlier, is a short acting drug. Now let's move on to reversal of non-depolarizing agents. Why do you need a reversal agent? Basically, in certain situations, we have gone for an intubation, we have given the drugs, both say induction agent and paralytic agent. But once you go in for intubation, we cannot intubate. So there is a possibility of cannot intubate situations. In this situation, the biggest issue that we'll have is the patient is not going to ventilate. So only thing that you can maintain the ventilation is by bag and mask ventilation. But because of the certain drugs that we have discussed earlier, their duration of action is 30 to 45 minutes. So ventilating that long has its own consequences. Hence, we have certain drugs which has been introduced which will help in reversing the agent. The two drugs are neostigmine and sumatriptan. Neostigmine has its own concern because it can only reverse up to 40% and it cannot produce fully reversal. Hence, the newer drug, that is sumatriptan. Now coming to neostigmine per se. What does neostigmine does? As I told earlier, the acetylcholine from the presynapse is coming into the synapse, is going to stimulate the acetylcholine receptor, and it goes and produce stimulation. That's a normal pathway that happens. and this is broken down by the acetylcholinesterase. Now what happens in the non-depolarizing or competitive blocker is that the drugs like rocuronium or vecuronium is going to stick onto the receptor, and as a result the receptor is blocked. So even if acetylcholine comes in, it cannot act. Now neostigmine, what it does is it prevents the breakdown of acetylcholine by inhibiting the acetylcholinesterase. So acetylcholinesterase cannot break down the the drug that we have, that is the acetylcholine. Hence acetylcholine is going to remain in the synapse. So you have the acetylcholine that is comes from the presynapse into the synapse, and it is broken down by the acetylcholinesterase. Now neostigmine is going to block the acetylcholinesterase. As a result, the acetylcholine is not broken down. So we have an increased concentration of acetylcholine at the synapse. So once the increased concentration is there, these acetylcholine can directly stimulate the motor end plate, even if the receptors are competitively blocked. And as a result, there is some muscle function or some depolarization or contraction that can happen to the muscles. As I told earlier, this is not 100%, just 40 to 50%, and it is not an ideal agent, but it can produce some recovery. The dose is 0.06 to 0.08 mg per kg. Now the newer drug is Sugammadex, which has been found to have a good role in reversal, in especially in rocuronium and vecuronium sort of when it is used with rocuronium or vecuronium. Here the adverse effects are very less, and it has a good effective response in reversing rocuronium induced blocking. The dose is 4 mg per kg IV. Rarely in emergency situation we can give up to 16 mg per kg. Okay. Now we move on to the depolarizing agents. The depolarizing agents are non-competitive blockers. As said earlier, you have the acetylcholine. It is two molecules of acetylcholine is succinylcholine. So it has some similarity, and it's a quaternary ammonium compound, so it has some similarity. Hence it is going to stick onto the receptor, acetylcholine receptor, and it has two phases. The phase one is the depolarizing phase, where it's going to stick onto and produce depolarization. The phase 2 is desensitization phase, where the receptor is desensitized, hence nothing can act on it. So as a result, the whole muscle gets stimulated, and it goes to fasciculation and then paralysis. The action starts from the small muscles like eye, jaw, larynx, and then it goes into the limbs and the trunks, and ultimately it is the intercostal muscles. The recovery is in the reversal order. The pharmacokinetic, and as a result, when we are giving succinylcholine, what we are looking at is the fasciculation that you're going to see in the toes. If that is there, that means there is a complete fasciculation has happened, and we can go ahead with intubation. It is a very rapid onset. Its action is between 30 to 45 seconds, and it's very short duration. It's only 5 to 10 minutes. As a result, there is no need of a specific reversal agent, because we just have to ambu for 5 minutes if it's a cannot intubate situation. Longer duration if needed, we can give a continuous IV infusion certain times. It is metabolized by pseudocholinesterase. The earlier acetylcholine was metabolized by acetylcholinesterase, whereas here it is metabolized by pseudocholinesterase. The half-life is prolonged in cases like neonates, elderly, and whenever there is a pseudocholinesterase deficiency, especially in liver disease and malnutrition. The biggest concern with succinylcholine is because of the fasciculation. It can release potassium into the cells. Potassium, as we know, potassium is an intracellular. Potassium is always put inside the cell. I always remind that potassium is KK is the king. King is always guarded. So basically, king is inside the cell. So once the stimulation happens, the potassium gets out of the cell and it's in the circulation, and patients can result in hyperkalemia. It can have a transient increase in intraocular pressure, so that is another concern that can happen. And there are rarely it can produce succinylcholine apnea in cases where there is a deficiency of pseudocholinesterase. As a result, the apneic period can increase. Arrhythmia or bradycardia can occur. Malignant hypothermia is another concern because of certain drug interaction, especially with general anesthetic agent like halothane. As a result, patient can have increased temperature, muscle rigidity and all those malignant hypothermia situations can occur, and we need to treat that patient rapidly with rapid cooling and Dantrolene sodium. I'll come into Dantrolene later on. And the patient can at times have muscle pain. The treatment of succinyl colon apnea, as I told earlier, because succinyl colon is a drug which is metabolized by pseudocholinesterase. If there is some deficiency of that, the patient can go into that apneic period. There is no antidote available. Only thing that we can do is ventilating the patient till it is fully recovered. There have been certain studies where fresh plasma has been infused and have shown some results. The risk, as I told earlier, because this can produce hyperkalemia and it is going to stimulate the muscles directly, there are some risk of using succinylcholine. And these are mainly in denervating injuries, like in stroke or spinal cord injuries. It's after 72 hours, there is not much, there is a risk of using succinylcholine. Similarly, there are diseases like multiple sclerosis and all, inherited myopathies, burns after 72 hours, crush injury after 72 hours, rhabdomyolysis, and if the patients are prolongedly immobilized, and if there is a severe intra-abdominal infections. These are also conditions where there is a risk of using succinylcholine. Now we move on to the drugs, its dose and its onset of action. As we discussed earlier, there are two groups, the depolarizing and the non-depolarizing. The most commonly used drugs in depolarizing category is succinylcholine. Its dose is 1 to 1.5 mg per kg with an onset of action around within 30 seconds. It was one of the most rapid onset of action with a short duration of action. So even if we cannot intubate in such any situations, we can just keep on ventilating, and within 4 to 5 minutes its action gets weaned off, and mainly because of the pseudocholinesterase action and all those things we have discussed about it earlier. When comparing that, succinylcholine has been long-standing drug, and it can produce very smooth intubation environment. When it comes to the non-depolarizing agent like vicuronium, rocuronium, atrocurium, it's mainly based on the ED95 of the succinylcholine. ED95 is the dose required to achieve the desired effect in 95% population. So when compared to the three drugs, the vicuronium, rocuronium and atrocurium, the drug which I want to discuss more is rocuronium. Rocuronium is a drug which is most commonly used in rapid sequence intubation because of its rapid onset of action. But as I discussed earlier, the ED95 concept, from that concept, what you have to understand that even the rocuronium dose that used in non-depolarizing agent is 0.6 to 1.2 mg per kg. If you're using a 0.6 mg, then the pre-ventilation time is around 2 minutes, whereas if it is 1 mg per kg, then the pre-ventilation is around 90 seconds. Whereas if you're using 1.2 mg per kg, then you can have the complete onset of action within 45 to 60 seconds. So that is a three-phase that we have to understand about rocuronium. And rocuronium, the another advantage is because even though it is having a rapid onset of action, even though duration of action is more, and if at all a cannot intubate situation comes in, we can use Sumadex as a reversal agent. So because of the rapid onset of action and the reversal agent is available, this drug can be used as a replacement for succinylcholine. So understand, rocuronium are for rapid sequence intubation. So rocuronium for rapid sequence intubation. When compared to other two drugs, vicuronium and atrocurium, understand the dose. For vicuronium it's 0.1 to 1.15 mg per kg. Onset is around 2 to 3 minutes, and around atrocurium is also 0.3 to 0.6 mg. Even though its onset starts by 90 seconds, vocal cord paralysis and all happens by around 2.5 to 3 minutes, 3.2 minutes. So those two, the onset of action is more. So rocuronium, remember rocuronium as one of the drug which has rapid onset and has a reversal agent. Now coming to Dantrolene. Dantrolene is not a neuromuscular blocking agent. It's a directly acting skeletal muscle relaxant. It basically inhibits the depolarization of the muscle by induced calcium release from the sarcoplasmic reticulum. Why Dantrolene I wanted to bring it here was, we have told earlier that if there is a drug interaction with halothane and if that goes to malignant hypothermia, Dantrolene is the drug of choice. Again, that is basically because we need to produce muscle relaxation. The dose is 1 to 2 mg per kg. Now we move on to the special situations. Special situations with neuromuscular agents are in myasthenia gravis. As you all are aware, myasthenia gravis, there are antibodies which are produced against acetylcholine receptors. So acetylcholine receptor, all this acts at the acetylcholine receptors. So myasthenia gravis is going to produce damage to the acetylcholine receptors. Hence, there is no receptor. So how do you manage such cases? In such cases, if you are using a depolarizing agent like succinylcholine, if you are using a depolarizing agent like succinylcholine, what you need is a higher dose of the drug. So we are going to give a higher dose. Earlier we used to give around 1 to 1.5 mg. Now you are going to give around 2 mg per kg because we don't have much receptors. So we are going to have higher dose to produce that stimulation and paralysis. So we are going to produce higher dose. When it comes to non-depolarization, which is basically a competitive blocker, here we have to smaller the dose because there are only smaller number of receptors. So rocuronium, instead of 1 mg, you're going to use 0.6 mg per kg, and vecuronium, instead of 0.15 mg per kg, we are going to use 0.06 mg per kg. So we are going to shorter the dose. This is 1 mg per kg. Sorry. So we are going to reduce the dose if we are using a non-depolarizing. Then the next situation is if at all we need to give intramuscularly. Commonly the route that we use is intravenous. There are also studies if IV is not there, and if we have an intraosseous line in place, we can use the same dose. But if at all, very rarely, if IMs are used, there is not much studies to go into the depth about it. There is one in the Annals of Emergency Medicine 2015 where what is said is that if it is using succinylcholine, we have to use almost 4 mg per kg, and the approximate is 2 minutes for adults for the onset of action instead of 30 seconds, and in children this can go up to 4 to 5 minutes. So this is the conclusion of the study. So it's not routinely used, not much studies to counter it, but I just want to bring that there is a possibility that it can also be given intramuscularly. Now we will come into the drug interaction. So drug interaction of both non-depolarizing and depolarizing is discussed separately. Most importantly, non-depolarizing blockers, as we discussed earlier, anticholinesterase like neostigmine can reverse the action of only non-depolarizing blockers, not depolarizing. Certain drugs like halothane, aminoglycosides, and calcium channel blocker can enhance neuromuscular blocking. So when using with the non-depolarizing drugs, we have to be careful. When it comes to depolarizing agents, the biggest concern is with halothane, when basically halothane is also used at certain times along with these drugs, and it can result in malignant hypothermia. And we have talked about dantrolene sodium, about how it is given in malignant hypothermia. With that, we have covered most of the topics that we have put in the agenda. Our agenda for the day was about to talk about skeletal muscle relaxants. We have classified it. We have talked in detail about both non-depolarizing and depolarizing agents and its mechanism of action. And we have also talked about the reversal agents and the special situation. Now let's put it all together. We are just comparing both the drugs, non-depolarizing and depolarizing. Non-depolarizing are competitive blockers, whereas depolarizing is a persistent depolarization of the distal muscle end plate is going to happen. There is no depolarization here, whereas in the depolarizing it is going to produce persistent depolarization. It's a single blocking, whereas as I told earlier, there are two phase, that hence it is a dual blocking. Is the acetylcholinesterase reverse the blockade, whereas here there is no specific reversal agents. Initial fasciculations is not present, whereas this is going to produce fasciculation and then paralysis. It has a slow onset but long duration. Here it is more rapid onset and shorter duration. It has a chance of the newer drugs have less histamine release, but there is an histamine release with older drugs. These does not have any histamine release. So this is just the comparison between both the agents, and as discussed earlier, these are the various doses that you have to be aware about each of the drug. Whereas as said earlier, Succinylcholine and vecuronium. Succinylcholine is one category, whereas vec-roc-atracurium comes under another category. Succinylcholine is going to produce depolarization and then paralysis, whereas vecuronium, rocuronium, atracurium is going to block the receptor and then produce paralysis. So this is in nutshell about neuromuscular blocking agents. If there is any queries, you can put down in the comments, or you can mail me or WhatsApp me. I hope this session was useful. You can the section is combined with the session that has been taken earlier about rapid sequence intubation, and you can look into that to know about in detail about how do you go for rapid sequence intubation. And this is mainly covering the neuromuscular blocking agents. With that, I conclude. Kindly subscribe. If you have any other sessions that I need to cover, you can put down in the comment or you can message. Thank you.